Welcome to the Australian Dental Council Explainer podcast. Just a quick note before we jump in. Please keep in mind that this content is purely educational and is not a commercial endorsement of any kind. So imagine walking into a clinic with a tiny, newly formed gap between your front teeth.
Right, expecting an easy fix.
Exactly. You're expecting a quick cosmetic fix, maybe a new crown, maybe some bonding, only to be told you are about to lose your teeth entirely. Today, we're doing a deep dive into how a painless, invisible disease fools both patients and clinicians.
And, well, how you manage that explosive reality in the chair, which is definitely the hardest part. We're pulling the scenario straight from a cornerstone text of dental education, Odell's Clinical Problem Solving in Dentistry.
Such a great resource.
Oh, it's essential. Specifically, we're tackling case 54, a gap between the front teeth. The goal here is to deconstruct a highly specific aesthetic complaint and, expand it into a comprehensive clinical evaluation.
Which mirrors the exact problem-solving pedagogy required to master the ADC OSCE exam. And because we want to get your diagnostic gears turning right away, I'm actually pinning a comment to the top of this deep dives discussion board.
I love this idea.
Yeah, so over the next 2 minutes, we're going to lay out the initial patient presentation. I challenge you to listen to these facts, hit pause on the audio, and drop your initial differential diagnosis in the comments before you hear our breakdown.
Let's set the stage then. So, a 35-year-old man walks into your clinic. His primary complaint is that he's noticed a gap appearing between his crowned upper right central incisor and the adjacent lateral incisor.
Okay, upper right, central, and lateral.
Right. And he first noticed this gap about 9 months ago. Over that time, he feels it's actively enlarged, the teeth appear to have drifted forwards, and he notes that the crowns now feel loose.
Looking at this presentation, my first thought always goes to the medical background. I mean, does he have any systemic conditions that might compromise his host response?
Well, medically, he has mild asthma, which is controlled with an inhaled corticosteroid and salbutamol. Dentally, he's a completely new patient to your practice.
Oh, okay. A new patient. Do we know his dental history?
He mentions he used to be a regular attender, seeing a dentist every 6 months, but he's lapsed for the past few years. Those metal ceramic crowns on his central incisors are about 6 years old, placed to replace unsightly fillings.
Got it.
Crucially, though, he is a non-smoker, and he has absolutely no pain in his mouth.
All right, if you were listening, this is your moment. Pause the audio. Consider the profile: 35-year-old non-smoker, asthmatic, 9-month history of a widening gap, drifting and loose anterior crowns, no pain, lapsed attender.
It's a lot of clues packed into one paragraph.
It really is. So drop your differential diagnosis in the comments. And assuming you've made your guess, let's analyze this history. The medical profile often serves a dual purpose in these exams, right?
Yeah, absolutely. It tests your medical management, but it also establishes a biological baseline.
I was actually wondering about the asthma medications. We know inhaled corticosteroids can cause local immunosuppression, bringing up the risk of oral candidiasis if he doesn't rinse. But could the steroid use be systemic enough to, say, mask an inflammatory response in his gingiva?
It's a smart thought, but no. The localized effect of an inhaled steroid is generally superficial to the mucosa. It really wouldn't drive the kind of deep structural failure we're hinting at here.
So it's a bit of a distractor.
Exactly. The much bigger clue is the specific designation that he is a non-smoker. The text highlights this before we even look at his periodontium because smoking fundamentally alters the physical presentation of periodontal disease.
Due to the vascular response, right, because nicotine is a potent vasoconstrictor.
You hit the nail on the head.
So in a heavy smoker, the gingival tissues might look deceptively pink and firm. The peripheral blood vessels in the gums are constricted, so you just don't get the classic erythema.
Right, you don't see the redness or the bleeding on probing that usually screams inflammation. A smoker can harbor profound periodontal destruction like deep pockets, massive alveolar bone loss, while presenting with a seemingly healthy-looking, fibrotic gingival surface.
It's terrifying, honestly.
It is, but the fact that this 35-year-old is a non-smoker means his gingival tissues are going to tell us the truth. We won't see that chemical masking effect. If there's inflammation driving this tooth mobility, it should be visibly apparent the second we look inside.
Which brings us to the most alarming part of his history. He's noticed a widening gap, drifting teeth, and loose crowns for 9 months, yet he delayed seeking care.
Because he felt no pain.
Exactly. It's fascinating how human psychology dictates that if it doesn't hurt, it just isn't an emergency. I tend to visualize periodontal disease less like a crack in a windshield and more like termites in the structural framing of a house.
Oh, that's a great analogy.
Right, because the drywall, the gums, might look perfectly painted, especially from a distance, but underneath, the osteoclasts are quietly hollowing out the alveolar bone. By the time the walls actually wobble, which is what we see as grade 2 or 3 mobility, the damage is already catastrophic.
That mechanistic view is essential for clinical reasoning. I mean, drifting and mobility without pain are massive red flags for chronic, silent pathology.
Compared to an acute infection like irreversible pulpitis.
Right, or a rapidly expanding periapical abscess, which triggers a massive inflammatory exudate in a confined space. That pressure on the nerve endings drives a patient to the clinic in the middle of the night.
Because the pain is unbearable.
Exactly. Chronic periodontitis, however, is an open system. The inflammatory infiltrate and the osteoclastic activity happen really slowly, and the pocket allows for drainage. It's famously painless until the terminal stages.
Like when an acute periodontal abscess finally forms, or the tooth literally occludes prematurely because it's drifted out of its socket. So if the underlying bone architecture is failing silently like you suggest, the physical evidence in the mouth has to reflect that.
Once we look past the shiny restorations, yeah.
Moving to the intraoral examination, what does the clinical picture actually reveal?
Well, the source material notes that his overall oral mucosa is healthy. There's no overt caries detected, and he only has a few amalgam restorations in the posterior. But locally, right at the site of the complaint, there is focal marginal inflammation and interdental plaque accumulation.
What about the crowns themselves? I mean, they are 6 years old. Are they failing? Is there a recurrent decay or maybe an overhanging margin causing a localized plaque trap?
That's the interesting part. The metal ceramic crowns actually have clinically sound margins. The restorative work itself has held up beautifully.
Wow, okay, so the failure is entirely biological.
Entirely. There's 3 millimeters of palatal recession on those central incisors, and both ground teeth exhibit grade 2 mobility.
To put a technical pin in that for a second, grade 2 mobility means we're observing horizontal movement of the tooth crown greater than 1 millimeter but less than 2 millimeters, with no vertical depression into the socket.
Exactly. The tooth is swaying, but it hasn't completely lost its apical support yet.
It's like putting a beautiful, expensive new roof on a house, only to realize the foundation is slowly washing away in a landslide.
That's exactly what's happening. But a comprehensive exam can't stop at the site of the chief complaint. When evaluating a localized anterior issue, you must evaluate the opposing arch and the occlusal scheme.
Right, because they interact.
And in the lower arch, we find a critical validating clue. There's another diastema between the lower right canine and the first premolar. And the adjacent lateral incisor has severe grade 3 mobility.
Grade 3 mobility on a lower lateral incisor. That means severe horizontal mobility, well over 2 millimeters, combined with vertical depressibility.
Yes, you can physically push the tooth down into the socket because the periodontal ligament is so severely compromised, it's essentially hanging on by a thread of apical tissue.
This is where we see the concept of pathologic migration in real time. The drifting of anterior teeth is a classic hallmark of advanced periodontal attachment loss.
Because as the alveolar bone height diminishes, the center of resistance of the tooth moves apically. The teeth can no longer withstand normal physiological forces.
Wait, let's break down the physics of that for a second. We often hear the term neutral zone in prosthodontics and periodontics. That's the physical space where the outward pressure of the tongue perfectly counterbalances the inward pressure of the lips and cheeks.
Right, which keeps the teeth stable in the arch.
So when the bone mites away, the teeth lose their anchor. The tongue is still exerting the exact same outward force during swallowing and speech, but the resisting bone is gone.
So the tongue effectively pushes the teeth forward, splaying them outward, creating these widening gaps. It's a perfect biomechanical breakdown.
And as they migrate, they hit differently, right?
Right. Yes. Furthermore, as the teeth migrate, they often encounter premature occlusal contacts, which introduces secondary occlusal trauma. This traumatic force accelerates the localized bone destruction and widens the periodontal ligament space even further,
Creating a vicious cycle of mobility and migration. Okay, so we have our visual and tactile evidence. We see pathological migration, grade 2 mobility on the upper centrals, and grade 3 mobility on a lower lateral incisor.
But in an ADC exam setting, observation and palpation just aren't enough.
No, you must justify your next diagnostic steps to definitively confirm why this destruction is occurring. According to Odell's text, What clinical investigations are we ordering next?
The clinical guidelines explicitly mandate that your first investigation here must be vitality testing.
Wait, really?
Yep. You need to perform sensibility tests, such as cold tests with endo ice or electric pulp testing on all the teeth in the upper right quadrant.
I have to challenge that sequence a bit. We have a patient presenting with classic signs of advanced localized periodontitis. We see plaque, marginal inflammation, recession, and pathologic migration. Why are we starting with endodontic vitality tests instead of immediately mapping the periodontal pockets?
I know, it feels counterintuitive, but failing to test vitality is a classic diagnostic trap. While advanced periodontitis is the most probable culprit for the mobility, you must definitively exclude an endodontic etiology.
To make sure it's not a necrotic pulp.
Exactly. A tooth with a necrotic pulp can develop extensive periapical pathology. This infection can drain through the periodontal ligament space, mimicking a deep periodontal pocket and causing profound mobility.
The classic endoperio lesion, or even a primary endodontic lesion mimicking periodontal disease. If bacteria from a necrotic pulp exit through a lateral canal or the apical foramen, they can rapidly destroy the adjacent alveolar bone.
It essentially turns a tooth infection into an inside-out gum infection.
That's a great way to visualize it.
And conversely, in cases of severe primary periodontitis, the destruction can progress so deeply that the periodontal pocket exposes lateral canals or the apical foramen to the oral flora.
Does the bacteria from the gum pocket invade the pulp?
Right, retrogradely, causing secondary pulp necrosis. If you blindly plan complex periodontal surgery or splinting without realizing the tooth is actually necrotic, your treatment is destined to fail.
Ruling out the endodontic component really is the ultimate plot twist in the diagnostic process. It ensures your entire treatment plan isn't built on a false premise.
Exactly. And once we confirm the teeth are vital and we're indeed dealing with the primary periodontal issue, we need radiographic evidence. We need to see the architecture of the bone.
So radiographic assessment is the mandatory second step. If I'm an anxious candidate in an OSCE, or even just a busy clinician, my instinct might be to order a panoramic radiograph in OPG. It's quick, gives a comprehensive survey of the mouth.
The sinuses, the TMJs, yeah.
Is an OPG sufficient to diagnose this case?
An OPG gives you a wonderful macroscopic landscape, but for this specific presentation, it's a dangerous tool to rely on exclusively. The text, particularly referencing figure 54.4 in Odell, specifies the absolute need for periapical radiographs.
Let's elevate this for the professionals listening. Why exactly does the panoramic radiograph fail us in the anterior sextans? It comes down to the physics of the focal trough, doesn't it?
It absolutely does. Panoramic machines capture an image by rotating around the patient, keeping a specific U-shaped layer of anatomy, the focal trough, in sharp focus.
And anything outside that trough becomes blurred or magnified.
Right. The anterior teeth are notoriously difficult to position perfectly within that narrow focal plane. If the patient's chin is tipped slightly too high or too low, or if they bite a millimeter too far forward on the bite block, the anterior teeth become distorted.
Or severely blurred. And beyond the focal trough issue, you also have the superimposition of the cervical spine.
Oh, that's a huge problem.
Because the X-ray beam passes through the dense vertebrae of the neck before hitting the anterior teeth, which often casts a radiopaque shadow right over the central incisors. It obscures the delicate trabecular pattern of the alveolar bone.
Which is exactly why periapical films are non-negotiable here. A properly taken periapical using the paralleling technique provides a high-resolution, unmagnified, and undistorted view.
You need that absolute microscopic clarity.
You really do. You need it to accurately trace the lamina dura, evaluate the localized alveolar bone crests, measure the exact crown-to-root ratio, and examine the width of the periodontal ligament space.
Especially when you're dealing with grade 2 and grade 3 mobility. A single millimeter of bone dictates whether a tooth is salvageable or hopeless. The OPG just cannot guarantee that millimeter of accuracy in the anterior region.
The PA gives you the microscopic truth.
Okay, so let's say we have our periapicals. They confirm our worst suspicions. We have advanced localized attachment loss, angular bone defects, and widened PDL spaces secondary to occlusal trauma.
We have our clinical and radiographic diagnosis.
Now we arrive at what is arguably the most complex and intimidating part of the OSCE, and frankly, of daily practice. Communicating this reality to the patient and formulating a treatment plan.
This is where clinical problem-solving transitions from a scientific exercise into a deeply psychological human interaction. The text heavily emphasizes that all details must be discussed transparently with the patient.
And transparency is a heavy requirement here. Because let's remember the patient's psychology. This 35-year-old man came in thinking he just needed a new crown to close a cosmetic gap.
Right, he's expecting to leave with a quote for a piece of porcelain.
He did not come in expecting to be told his bone is gone and his teeth are falling out.
Breaking that news requires a very structured approach. Transparency means actively dismantling his cosmetic assumption and laying out the harsh reality of the biological failure.
You have to explain the time commitment, the behavioral modification.
By drastically improving his oral hygiene.
Right. And the significant financial costs required to treat advanced mobility. Periodontal therapy, potential splinting, extraction of hopeless teeth, and complex prosthodontic replacement. It's a long, arduous road.
And the guidelines dictate that a written treatment plan must be provided for the patient to consider. It cannot just be a sympathetic verbal chat. Informed consent requires documentation, especially when the prognosis is guarded.
Right. And the source material notes a very specific and highly common complication in this scenario. After hearing the bad news, the patient strongly pushes back.
They almost always do. In this case, he indicates that he wants to attempt to preserve that lower right canine, regardless of what you've told him.
Even though as the clinician, looking at the advanced bone loss and the clinical mobility, you know the prognosis is practically hopeless. How do you manage a patient who is effectively in denial and demanding heroic, likely futile dentistry?
You're navigating a classic clinical dilemma. You handle this through the framework of shared decision-making. You don't just adopt a paternalistic approach and dictate treatment, but you also cannot perform supervised neglect.
Or ethically questionable dentistry just because the patient asks for it?
Exactly. You have to clearly explain the mechanism of failure to the patient. Attempting to save a severely compromised tooth carries a high risk of spontaneous acute infection, continued bone destruction that might compromise adjacent teeth, and frankly, wasted financial resources.
But what if you explain all of that and he still wants to try periodontal debridement and splinting to save the canine?
Well, if retaining the tooth temporarily does not cause systemic harm, and there is a theoretical, albeit slim, chance of retention through intensive non-surgical periodontal therapy, you meticulously document his informed consent.
You write down explicitly that he understands the poor prognosis and the high likelihood of failure.
Yes, but more importantly, shared decision-making requires contingency planning.
You essentially have to plan for the failure before you even start the treatment.
You must discuss the specific options for an immediate replacement prosthesis for when those upper central incisors, or that lower canine, eventually fail. Do you use a transitional acrylic partial denture?
Or are the adjacent abutment teeth stable enough to support a resin-bonded adhesive bridge?
Exactly. Or do you need to discuss the reality of an immediate complete overdenture if the entire anterior segment is compromised? You never leave the patient without a clear roadmap for what happens when the worst-case scenario occurs.
It really hits home that modern dentistry and the core philosophy underlying the ADC examinations isn't just about identifying grade 2 or 3 mobility. It's not just about knowing the physical limitations of an OPG versus a periapical film.
It's about treating the human being attached to the teeth.
It's about empathy, incredibly clear mechanistic communication, and structured, patient-centered care. You have to be an expert in pathology, a master of biomechanics, and a skilled psychologist.
Which is exactly why these case studies from Odell's text are so incredibly valuable. They force you to synthesize isolated textbook facts into dynamic, real-world clinical conversations.
I want to leave you with a final thought to mull over as you prepare for your clinics or your exams. Imagine you are sitting knee-to-knee with this 35-year-old patient. He's looking at you, expecting a quick fix for a cosmetic gap. Knowing everything we just discussed, the silent osteoclastic activity, the grade 3 mobility, the necessary extractions, the impending prosthodontic journey, how exactly do you script the first sentence out of your mouth to break the news that he might lose his front teeth entirely? Do you start with the radiographs? Do you start with his symptoms? It's a communication challenge that goes far beyond textbook clinical skills. And mastering that transition is what separates a good clinician from a truly great one.
It's the ultimate test of chairside manner.
For more dental examination prep tips and clinical deep dives, please subscribe and share this episode.